Right. So, hello everyone. Can you please let me know in the chat box if my audio and video is visible? Okay. Please let me know in the chat box if my audio and video is visible. Yes. Good evening. So, I think we can start the session, and I think it's all good to start. Yeah. Good evening, Aisha. Good evening, Ness, Indu. Good evening. So, basically, this will be the recall session of the medicine questions of NEET PG 2024. But I think this is going to be something very useful for you because I've arranged it system wise. As you all know, in NEET PG 2024, we had two shifts. There was shift 1 and shift 2. So what I have done is I've collected the questions of both the shifts from the students, and I've segregated it system wise, including the core medicine questions as well as certain integrated questions, wherein medicine is linked to, say, radiology or pathology. So I hope all of you have got access to the file as well, which I've shared in my academic WhatsApp groups. I hope you have got the PDF of this session. And yeah, I think we'll start. This is the QR code of my academic Instagram page. In case you are not there in any of my academic WhatsApp groups, you can just send me a message in Instagram. I shall send you the link for the groups. Right. And this is the QR code of my Instagram WhatsApp. I mean, in the QR code of my WhatsApp channel, wherein I put MCQs, so you can be in this group as well. Okay. So, right. So let's start. This will be a quick pace session, okay, of the recall questions of NEET PG 2024. So let's get started. Okay. Right. And the first question, a 27-year-old professional footballer suddenly collapsed during a match and could not be resuscitated. Autopsy revealed left ventricular hypertrophy. A representative histopathology image is provided. What is the likely diagnosis? The image is given. Four options: dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, and constrictive pericarditis. So always when you deal with such scenario-based questions, please properly analyze. Here we have got a young professional footballer, just 27 years, who has suddenly collapsed during a match and could not be resuscitated. Now, this is one favorite question for NEET PG, wherein uh, young people engaged in sports having sudden death. One of the important differential diagnosis that you should consider is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, right? Let us see whether the remaining part of the question substantiates the same. You can see that the autopsy revealed left ventricular hypertrophy, and the representative histopathology image is also provided. So there is some sort of muscle hypertrophy, and we know that in case of hypertrophic cardiomyopathy, you will have the predominant hypertrophy that is involving the ventricles. It involves the left and the right ventricles, more in the left ventricle, and it predominantly involves the interventricular septum as well. And I'm sure that all of you have heard of this term, asymmetrical septal hypertrophy. That is, the septum is disproportionately hypertrophied in comparison to the left ventricular free wall. Now, let us have a look at the histopathology image. Can somebody tell me in the comment section, what is the representative histopathology image telling us? What story does it convey? Well, all of you should know something that in my routine lectures also I have taught you in the module on hypertrophic cardiomyopathy. And this is one such image which has been taken from Harrison's textbook. You can see that in hypertrophic cardiomyopathy, you will have something that is known as myocyte disarray. Very, very important point. Please note it down. Myocyte disarray. okay, a very haphazardly arranged myocytes. So one point is there is myocyte disarray. The other point is there is myocyte hypertrophy. Three important points that you should know: myocyte disarray, myocyte hypertrophy, and also you will have interstitial fibrosis. Three very important points that all of you should know: interstitial fibrosis. And another MCQ point. So these 3 points all of you should be knowing. Okay, so you can see here there is a disarrayed myocyte architecture with some sort of swirling and branching. So in a normal myocyte, you will have a parallel arrangement of the myocytes. That is what you see normally. But instead of the parallel arrangement of the myocyte fibers, here you will have some sort of swirling and branching, which is also referred to as the helter-skelter pattern as well. That is also another potential question, the helter-skelter pattern. So let me just again show you another image. Look at this. This is the normal myocardium, and just compare the arrangement of the myocytes in comparison to the hypertrophic cardiomyopathy, where you will get myocyte disarray. Very important. So this again is substantiating that the diagnosis is hypertrophic cardiomyopathy. So the answer for this question is going to be option B. A couple of additional points. See, where do you get the ninja star nuclei? Can you tell me? In histopathology, the ninja star nuclei is seen in what condition? You can see the arrows pointing towards the ninja star nuclei. This is seen in case of dilated cardiomyopathy. This is another potential question which may be asked. Okay. And another question is, when you get a scenario of a cardiomyopathy, mostly in the setting of, say, an amyloidosis, you must think about restrictive cardiomyopathy. And what do you get in RCM or restrictive cardiomyopathy? You will get the deposition of pink amorphous material. Are you seeing this? You will see the deposition of pink amorphous material, which is nothing but the amyloid. Again, important. So I hope I have covered a few additional points that you should know related to this particular topic, right? Okay. Now, in the set 1, the previous question was asked, whereas in the post-lunch session, the set 2, another question was asked about hypertrophic cardiomyopathy. Let us see what that question was. A 30-year-old athlete is diagnosed with hypertrophic obstructive cardiomyopathy with a harsh systolic murmur along the lower left sternal border. He also has a brother who died of sudden cardiac death. So the first 2 sentences again substantiates that the diagnosis for this condition is definitely hypertrophic cardiomyopathy without any doubt. Now, what is the question? Which of the following murmurs would increase the intensity of this murmur? That is the murmur of hypertrophic cardiomyopathy. This is something I have stressed in my lectures, especially the lecture on the murmur part. In the QRP section, there is one segment on the murmurs, which I have summarized into a very short video. And I have told you about the various murmurs and the intensity changes with various maneuvers. And this hypertrophic cardiomyopathy is very, very important. I'm sure those who have listened to the QRP lecture would remember this table, wherein the dynamic auscultation based on various maneuvers I have explained. Now, look at this. I've told you in that lecture that MVP as well as HOCM behaves differently compared to other murmurs. So can you tell me, look at this, any sort of maneuver that increases the preload, like passive leg raising and squatting, will decrease the intensity of the murmur. Whatever I have highlighted in green, I have written in green, it's basically maneuvers that decrease the intensity. Okay, the murmur intensity will be decreased by that particular murmur. And whatever I have written in red, the particular maneuver will increase the intensity of murmur. So you can see that passive leg raising and squatting, I'm already eliminating those options because they are going to decrease the intensity of the hypertrophic obstructive cardiomyopathy murmur. And you can see that hand grip, isometric hand grip, is again decreasing the intensity of the HOCM murmur, which is why I'm eliminating that option as well. Now, what about Valsalva? Valsalva as well as standing will decrease the preload, and hence it will increase the intensity of the HOCM murmur. Very, very important. Most of the other murmurs are decreased with the decrease in preload, like in standing or Valsalva, with the exception of MVP as well as HOCM, the intensity of which is increased. So what is going to be the answer for this question? It is going to be option B, Valsalva, right? Let's go to the next question. 58-year-old woman presents with progressive exertional dyspnea and fatigue over the past 3 months. On examination, she has elevated JVP, bibasal crackles, and S3 gallop. Echocardiography reveals a left ventricular ejection fraction of 35%. Very, very important. 35%. Which of the following drugs has been demonstrated to reduce the mortality in such patients? So when a patient presents with progressive exertional breathlessness for the past 3 months with bilateral basal crackles and S3 gallop suggestive of a left-sided heart dysfunction and an elevated JVP suggestive of a right-sided heart dysfunction, we are thinking about a biventricular dysfunction, which is also known as a congestive heart failure, right? So in this particular patient, you can see the ejection fraction is significantly decreased. It is 35%. So basically, we are dealing with a scenario of a patient having a heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction. Now, can someone tell me, when do you call it heart failure with reduced ejection fraction? When the EF goes below what level? Anybody can comment? It is below 40%. So if you remember this particular slide that I have taught you in the revision videos on the pharmacological therapy of chronic heart failure. So you have got a heart failure with reduced ejection fraction, where the ejection fraction is less than or equal to 40%, as in this patient that we have seen, and heart failure with preserved ejection fraction when the ejection fraction is above 50%. Now, can anybody tell me when the ejection fraction is in the range of 41 to this 50%, what do you call it? 41 to 50%, what do you call it? It is called heart failure with mildly reduced ejection fraction. Okay, so that is that particular range or the border zone range. Now, in a patient with heart failure with a reduced ejection fraction, very important question, what are the 4 pillars? Have I told you this or not? Very, very important potential question. So the first pillar is ARNI. If ARNI is not available, what is ARNI? Angiotensin receptor blocker, neprilysin inhibitor. If ARNI is not available, you can opt for either an AC inhibitor or ARB. Correct or not? What is the second pillar? It is beta blocker. And among the beta blockers, what are the preferred ones? I've told you this mnemonic, the MBC beta blockers. Metoprolol, bisoprolol, carvedilol. Then the mineralocorticoid receptor antagonist like spironolactone and SGLT2 inhibitors like dapagliflozin, empagliflozin, right? These are the 4 pillars. Now, all these 4 pillars have got mortality benefit. That is important. Look, there are so many drugs that can be used in the treatment of chronic heart failure, but only some of them have got mortality benefit. And all the 4 pillars have got mortality benefit. All the 4 pillars have got mortality benefit. In addition to the 4 pillars, just one second. In addition to the 4 pillars, can you just wait one second? Let me just adjust. Right. Okay. So in addition to the 4 pillars, in selected populations, even the combination of hydralazine plus isosorbide dinitrate has also got some mortality benefit, but that is only in some populations. Okay. Then the other drugs that can be used in chronic heart failure include ivabradine and the guanylate cyclase stimulator, that is vericiguat. What about the role of digoxin in heart failure? Again, a potential MCQ. Remember, the role of digoxin in heart failure is in a patient who has a heart failure with reduced ejection fraction along with atrial fibrillation. Otherwise, in general, not that preferred. Whereas in case of heart failure with preserved ejection fraction, okay, you will not have these 4 pillars. Okay, the only drug which has got a definite proven benefit in heart failure with preserved ejection fraction is SGLT2 inhibitors. In addition to that, you may use diuretic therapy for fluid overload. So what do you think is the answer for this question? Yes, it is quite clear. It is bisoprolol. but a very, very important topic is this one. Okay, right. Just give me a thumbs up if you have understood the concept here. Next question, a 62-year-old patient with a history of hypertension and chronic kidney disease. So always when you analyze the case, you look at the background history as well. Patient is having hypertension and chronic kidney disease. And the patient is having what sort of symptom? Vague symptom. And what is that vague symptom? Generalized fatigue. And we have performed ECG in that patient. And the question is, which electrolyte disturbance is most consistent with these ECG findings? Now, even before you look at the ECG, in a patient with chronic kidney disease, what do you think? Which electrolyte abnormality are you expecting? Hyperkalemia. So with that mindset, just have a look at the ECG. Are you not able to appreciate the tall peaked T waves in this particular patient? And not just that, can you also see that some of the QRS complexes are beginning to get broader? So which is a sort of a sine wave pattern? Yes or no? So what do you think is the likely cause? It is definitely hyperkalemia, right? So the answer is going to be option A. Okay, hyperkalemia. Now, very important, when you look at hyperkalemia, you should know about the ECG changes. Yes, one I have just told you, tall peak T waves. But remember, as the severity of hyperkalemia increases, more and more ECG changes might appear. As I told you, in the early stages, tall peak T waves. In the next stage, there is loss of T waves, important. Subsequently, widening of the QRS as the potassium levels becomes 7 to 8 range. And when it goes above 8, you may get a sine wave pattern with predisposition arrhythmia as the QRS complexes get broader, and even the patient can land up in a asystole, right? So this is very important. Answer for this question is option A. Clear? Okay. Let's go to the next question. A 40-year-old female with pulmonary arterial hypertension on examination. So they've already given you the background disease of pulmonary arterial hypertension in this patient. The patient is having an irregular pulse and, as expected, a loud P2 on auscultation. Okay, but please note this finding also, irregular pulse. The question is, what is the finding that is most likely observed on JVP examination? Now, all my children, you know that in case of pulmonary arterial hypertension, you may have an associated right ventricular hypertrophy. And when there is a right ventricular hypertrophy, what is the expected ECG, expected JVP abnormality? Giant A wave. So you're already having the temptation to mark giant A wave, which is option B. But please, my dear students, look at this. The patient has got an irregular pulse, which means the patient probably has got an atrial fibrillation as well, AF. So when you have got an AF, which is superimposed on pulmonary arterial hypertension, do you think a synchronous contraction of atria is possible? Not possible. So the disorganized contraction of atrial muscles will result in an absent A wave. So though the patient is having a background history of pulmonary arterial hypertension, just because the patient has an arrhythmia like atrial fibrillation, wherein the atrial muscle fibers are contracting in a very chaotic manner, you're not going to have a wave, and the patient is going to have absent A waves. Right? Is it clear? Can you give me a thumbs up if it is clear for you? Slightly tricky question, this one, for your exams, but I hope you've got the concept right now. Okay. And this is one summary slide which I've already taught you in on the various JVP abnormalities and the associated conditions. Please do take a screenshot of this. It's very, very important. High probability question for NEET PG exams. Okay. Next question. Again, an interesting question. All of you, please listen carefully. So as I'm describing this question, you also try to come to a diagnosis, okay, so that you can also figure out whether you are able to understand. The question is, a 33-year-old presents with a progressive shortness of breath and pedal edema or a peripheral edema. On examination, his pulse is irregular and his JVP is elevated with a prominent Y descent. Auscultation reveals a high-pitched early diastolic sound. What is the most likely diagnosis? So my dear children, what is the patient having? progressive shortness of breath, right? Now, he is having some sort of edema and his JVP is elevated. So, my dear children, what do you think? Is it a problem predominantly with the right side of the heart or left side of the heart? It's a right heart failure. Correct or not? Yes. And the patient has got a prominent Y descent. Now, you remember out of the JVP abnormalities that I have taught you, where do you get a prominent Y descent? Yes, in case of constrictive pericarditis. Correct or not? Yes. So constrictive pericarditis. And what have I taught you? Constrictive pericarditis predominantly presents with right-sided heart failure or left-sided heart failure, right-sided heart failure. Clear. That is why this patient is having these manifestations. But what about the pulse? The pulse is irregularly irregular, which again probably tells you that the patient is having atrial fibrillation. Is it possible or not for a patient with constrictive pericarditis to have AF? It's possible. There can be atrial dilatation resulting in a disorganized atrial muscle predisposing to atrial fibrillation. Now, what is this high pitch early diastolic sound? What do you think this is? Can I have your answers in the comment section? Deepanshu, Fatima, Khushi, Gokul, what do you think? This could very well be a pericardial knock. This could very well be a pericardial knock, which is a diastolic sound which occurs slightly earlier than your S3. Possible or not? So the question is, which of the following is the most likely diagnosis? So I'm probably thinking about a constrictive pericarditis. What about the other options? Bicuspid aortic valve with aortic regurgitation. In aortic regurgitation, I'm expecting a murmur, an early diastolic murmur, and that is not there. I am eliminating that option. In case of rheumatic mitral stenosis, yes, AF can occur, but again, where is the mid diastolic murmur? It is not there. And the other, JVP abnormality is also not, corresponding to this. And what about cardiac tamponade? Remember, in cardiac tamponade, you get absent Y descent and not prominent Y descent. So I'm eliminating that as well. So constrictive pericarditis is what you should think about. And look at this slide from the quick revision program session. In constrictive pericarditis, you have got a rigid pericardium that impairs the cardiac filling, resulting in a decrease in the cardiac output. And mostly the constrictive pericarditis is due to healing and scar formation in a previous pericarditis case. And the patient presents with breathlessness. Very, very important, my dear children. It is often a right-sided heart failure. Okay, right-sided heart failure. An examination can show tachycardia, elevated JVP, edema, ascites, all suggesting, right-sided heart failure, a congestive hepatomegaly, and a diastolic sound, which is your pericardial knock, right? So that is quite clear. The answer for this question is option C, constrictive pericarditis. That is clear. Coming to the next question, an 18-year-old patient presents with fever and migratory large joint arthritis. So look at this, age is 18 years, right? What are the manifestations? Fever and an arthritis, which is migratory in nature and predominantly involves the large joints. Examination reveals an apical pansystolic murmur, which is likely to be the murmur of mitral regurgitation. The lab evaluation shows elevated ESR and CRP and a negative rheumatoid factor. What is the most likely diagnosis? What do you think? Now, let us try to eliminate here. Now, what about seronegative rheumatoid arthritis? We know that such an entity exists where the patient is having features of rheumatoid arthritis, but the RA factor is negative. So just because a patient has a negative rheumatoid factor, you cannot eliminate rheumatoid arthritis. But can this be a seronegative rheumatoid arthritis? Well, what is the age of the patient? 18 years, not favoring rheumatoid arthritis. And look at this. The patient is having a migratory nature of arthritis. Again, not well described with rheumatoid arthritis. And rheumatoid arthritis, though it can involve small and large joints, is predominantly a small joint arthritis. But here they're talking about a large joint arthritis. So I'm eliminating this option. In reactive arthritis, there should be some antecedent infection that has triggered the arthritis, but the arthritis is usually an asymmetric oligoarthritis. So that also I'm eliminating. Ankylosing spondylitis usually presents with low backache, buttock pain corresponding to sacroiliitis, and only in a small population of patients will it cause a peripheral arthritis. But that is not the picture that is mentioned here. And also an apical pansystolic murmur does not occur in ankylosing spondylitis. So let me ask you something. Can a murmur occur in ankylosing spondylitis? Is it possible or not? Let me see how many of you are able to answer. I'm waiting for your answers in the comment section. My question is, can a patient with ankylosing spondylitis have a murmur? So as I wait for your answers, I'm just eliminating this option. And yes, considering the age of the patient, the manifestations of arthritis, then carditis, MR could be due to the carditis, and with other features like fever, elevated ESR, CRP, this very well can be an acute rheumatic fever. Yes, so the answer is clear. Now coming back to this question, ankylosing spondylitis, remember my dear children, ankylosing spondylitis can have certain extra-articular manifestations. And among the extra-articular manifestations, have I not taught you that you can have aortic regurgitation? Possible or not? Because of the aortic root dilatation, you can have aortic regurgitation. You may get an early diastolic murmur. Okay, right. But again, the clinical picture is not corresponding to that. Let's go to the next question. Okay, which of the following drugs, when taken together with erythromycin, is most likely to cause what? QT interval prolongation and torsades de pontis. And look at the options. What is common to all these options? All of them are antihistamines. Astimizole, doxylamine, loratadine, promethazine. Now, there are so many drugs, so many drugs that can result in a QT interval prolongation. Now, look at this table. This is from Harrison. A list of drugs that can cause a prolongation of QT interval. This includes the antiarrhythmics, antibiotics, antipsychotics, and yes, antihistamines and certain other drugs. Now, when it comes to the antihistamines, what are the antihistamines that can cause QT prolongation? One is astimizole, then diphenhydramine, hydroxyzine, and even terfenadine. These are the drugs that you should be aware about. For this question, answer is astimizole, right? Let's go to the next question, right? 45-year-old man presents with sudden onset severe tearing type of chest pain. If you remember, in my Instagram, once I have made a reel on the characteristic chest pain of the aortic dissection, and I said this, tearing type of chest pain. So when a patient presents with a tearing type of chest pain, look, patients with myocardial infarction can also present with, the central chest pain, sometimes even of tearing nature. But look at this question carefully. The patient is having tachycardia, hypotension, but the tropi levels are negative. So if it was a myocardial infarction, you would expect that the cardiac biomarkers are positive, especially for such a severe type of presentation. So he could not be revived and post-mortem autopsy was done. So before I come to autopsy itself, my mind is already aligned with dissection as the answer, aortic dissection, right? This is how you should think in the exam. Be confident, you just try to formulate the diagnosis in the mind even before you go to the image, so that yes, once you see the representative image, you can make out the abnormalities quickly, right? So post-mortem autopsy, representative histopathological image shown. Based on the clinical and pathological findings, what is the most likely underlying pathology? What do you think? Can somebody answer? What do you think? What are you seeing here? Are you seeing a defect? Are you seeing a defect, a tear, a separation between the tunica intima and tunica media? And what is this? This is aortic dissection. We are dealing with a scenario of a dissection, aortic dissection. Okay, aortic dissection, right? So the question is not the diagnosis. They are asking which of the following is the most likely underlying pathology. What do you think? Is it connective tissue degeneration of the aortic wall? Is it fibrinoid necrosis with smooth muscle hyperplasia, fat deposition, vasculitis? What do you think? Well, it is not any sort of a fibrinoid necrosis. No. Fat deposition, smooth muscle degeneration, we are not talking about atherosclerosis. I am not seeing any fat here, eliminating that option. And vasculitis, again, my clinical suspicion is not that of a vasculitis. So what am I thinking about? This could be due to a connective tissue degeneration of the aortic valve. So my dear children, you remember this slide from the QRP videos? Aortic dissection, there is a disruption of the tunica intima, blood dissects into the media. And what is the most common site of aortic dissection? Another possible MCQ point, the right lateral wall of the ascending aorta. And remember, there are certain predisposing factors for aortic dissection that includes connective tissue diseases, bicuspid aortic valve, pregnancy, as well as hypertension, right? But in our case, they have not given any such predisposing condition, right? Let's go to the next question. A 58-year-old man with a history of hypertension presents to the emergency department with a sudden severe chest pain radiating to the back. On examination, there is significant difference in blood pressure between the arms and unequal radial pulses. Now here again, when you have a patient with a background history of hypertension, okay, having a sudden severe chest pain radiating to the back, here again you will think of aortic dissection. See, NEET PG 2024 had two shifts and questions from aortic dissection were there in both shifts. And you see how they have twisted. The topic remains the same. The important topic, the previous year topic, you have to be very thorough. But what they are slightly twisting is the way in which they have asked the particular question. So that's why you have to be very thorough with the previous year topics. Okay. Now on examination, significant difference in the BP and unequal pulses. CT angiogram was performed, and what are they asking? Is it regarding the diagnosis? No. What is the most appropriate initial management? So when I'm looking at the CT angio, I can very well see the intimal tear. Are you seeing this? Are you seeing the tear out here? Yes, I can very well see the tear, and I can see there is a false lumen and a true lumen. Okay, can I see this? This is one lumen, this is another lumen. So there is a true lumen, there is a false lumen. This is a dissection. And this dissection, is it involving predominantly the ascending aorta, the aortic arch, or the descending aorta? It's predominantly involving the descending aorta. And maybe, it is extending into the aortic arch as well. Now, when I have taught you about the management of aortic dissection, I have told you it depends. Depends on what? Is it Stanford type A or B? So if you remember this slide in my lectures on the classification of aortic dissection, you've got the Stanford as well as DBK classification. And in terms of the management, what did I tell you? Which is more important? Stanford. So based on the Stanford, you've got type A and type B. What is type A? Type A means the dissection is involving the ascending aorta independent of the site of tear and distal extension. It may involve the aortic arch, it may involve the descending aorta, but what is definitely involved? The ascending aorta. Whereas type B dissections, it is involving the transverse or the descending aorta without involvement of the ascending aorta. The transverse and or descending aorta, but the ascending aorta is not involved. So what do you think? As I can see in the comment section, many of you rightly telling this is Stanford type B, as correctly said by Dr. Deepanshu Mathur. Very good. So this is Stanford type B. Now when it comes to the treatment, if it is type A dissection, no doubt about it, we have to go for urgent surgical intervention, wherein you will replace the diseased portion of the aortic arch with a prosthetic graft. No doubt about it. Now in type B dissection, we will go for a surgical intervention only in one scenario. If there is a specific mention in the question that the patient is having some evidence of an organ malperfusion, a significant organ malperfusion. But otherwise, if it is a type B dissection without malperfusion, without the question specifically saying, most of the type B dissections can be managed, with aggressive control of the BP, you will try to keep the systolic BP in the range of 100 to 120 mmHg with a combination of sodium nitroprusside with a beta blocker or a calcium channel blocker, taking care to avoid a direct arterial vasodilator like hydralazine that can worsen the dissection. So what is going to be the answer for this question? What do you think? It is going to be option B, where you will go for aggressive BP control and close monitoring. But next time they might twist the question. They might show the tear in the ascending aorta, which would make it a Stanford type A. In that case, you will have to go for an immediate surgical repair, right? I hope that is clear. Let's go to the next question. 38-year-old patient presents with central chest pain and hoarseness for the past month. Okay, so a contrast enhanced radiographic image of the chest is provided. Which of the following is the most likely diagnosis? So you can very well see that there is an aneurysm that is involving the aortic arch, which is involving the distal part of the distal aortic arch. Can you see it? It is a saccular aneurysm. I'm not seeing, any evidence of a dissection. There is no stenosis, so it is not a coarctation of aorta, or it's not at all any sort of an aortic stenosis as well. I am seeing an aneurysmal dilation that is involving the distal part of the aortic arch, and hence the answer is for this question is option A. Right? Clear. Let's go to the next question. A 45-year-old male was on regular antihypertensive treatment for hypertension, despite experiencing certain side effects like constipation, dry mouth, and dizziness. So patient had these side effects, but in spite of that, he was taking that drug. Okay, so look at that. They're basically asking you which medication is responsible. So look at the side effects: amlo, clonidine, lisinopril, telmisartan. What do you think? Clonidine has these side effects, right? You know that dry mouth is very common side effect with clonidine. You can have constipation, you can have dizziness as well. But again, I'm not making premature conclusions. Let me read the remaining part of the question as well. Recently, he traveled abroad and forgot his medications. Since then, he has not taken them. So there is some sort of a drug default. Now he presents with hypertensive emergency. Now I'm very confident that the answer is clonidine, because clonidine is very well known to have a rebound hypertension. Yes or no? Yes or no, children? You tell me in the comment section. Rebound hypertension can occur on stopping clonidine. Okay. So what do you think is the likely diagnosis here? That or likely drug that the patient was taking? It is basically clonidine, right? Yes. All of you are comfortable. Sharon, Fatima, Indu, Gokul, right? I hope all of you are comfortable, right? Next question. 55-year-old male presents to the emergency department with sudden onset shortness of breath. So the scenario of a patient with a sudden onset breathlessness. The patient is having tachycardia, but with hypotension. An echocardiogram is revealing a diastolic collapse of the right ventricle. Chest X-ray is obtained. You can very well see that in the chest X-ray, there is an enlargement of the cardiac silhouette. Yes or no? There is an enlargement of the cardiac silhouette. Now, what do you think is the likely diagnosis in this patient? Always remember, sudden onset breathlessness, patient going into hypotension, very important finding, diastolic collapse of the right ventricle. This could be due to a cardiac tamponade. Okay, this can very well be due to a cardiac tamponade. And the X-ray is also showing a enlargement of the cardiac silhouette. The question is, what is the most appropriate immediate intervention for this patient? Okay, immediate intervention. First option, begin diuretic therapy and monitor BP in a patient with hypotension. Do you think you're going to give diuretics and further reduce the BP? No way, that's not my answer. Insert an IABP, that is not going to be the answer. Ventricular assist device, no. This is not a scenario of a heart failure in that context to go for these managements, but the life-saving procedure here is going to be a pericardiocentesis. So the immediate intervention is pericardiocentesis. The definitive treatment is, yes, a thoracotomy, but the immediate intervention is to let the fluid out. It is pericardiocentesis. Option D is the answer, right? Next is the routine ECG of an asymptomatic patient shows a PR interval of 0.21 seconds. So what is the normal PR interval? It is ranging from 0.12 to 0.2 seconds, which means 120 to 200 milliseconds. What is the most appropriate interpretation? Okay, so you can see that there is a slight prolongation of the PR interval. And by definition, a prolonged PR interval means something that is prolonged over 200 milliseconds. So here you can see that definitely it is prolonged. You can say that it is a mild prolongation only. Yes, but still it is prolonged. It is still prolonged. So which means it is not going to be normal. It is a first degree AV block. Even if the question mentions, okay, it is an athlete having this sort of a PR interval. See, it may be in the physiological, but according to the definition, it is a prolonged PR interval and the patient is having a first degree AV block. The answer for this question is option B. Last time, many students marked normal. Some students said, sir, it was mentioned athlete, so I thought, the ECG is normal. It is a physiological finding, but still it is an AV block. Okay, that is what you should understand. Next, this question was asked in the first shift of NEET PG 2024. Match the following. So look at this. You can see, it's almost like having 4 ECG based questions in one. Okay, they have given the match the following. What is the first one? What do you think? You are seeing that the ventricular rate looks normal, but you can see the atrial rate is very high, and you can very well see the sawtooth pattern of P waves. Okay, so it's basically an atrial flutter with an AV block. Yes, atrial flutter with an AV block. That is what you're seeing with the sawtooth P waves. Yes, you're seeing sawtooth P waves. Sawtooth P waves, right? Okay, atrial flutter. And what is the next one? You are seeing a regular narrow complex tachyarrhythmia. Yes, a regular narrow complex tachyarrhythmia with absent P wave. So what is it? It is going to be a paroxysmal supraventricular tachycardia. What about the next one? It is a wide complex, regular monomorphic wide complex tachycardia. It is a VT. Okay, and what about the last one? You can see it is an irregular narrow complex tachyarrhythmia with absent P waves. All you can see is the presence of certain fibrillary waves. So you're considering a diagnosis of atrial fibrillation, right? Okay, right. So for this question, the answer was option B, 1B, 2D, 3C, and 4A. Match the following. Okay, next question. A 50-year-old man with a history of hypertension presents with shortness of breath and palpitations. On examination, he has irregular pulse and bilateral basal crackles. ECG is shown. Which of the following statements is right? Now, what do you think? Patient has some sort of shortness of breath, background history of hypertension, irregular pulse. This can be due to atrial fibrillation and bilateral basal crackles, which means there is some sort of a left heart failure resulting in a cardiogenic pulmonary edema. So which of the following statements is incorrect? Incorrect. So IV digoxin can be used for ventricular rate control. So in a patient with heart failure, when is digoxin useful? In a patient who has a atrial fibrillation. So yes, it can be used. So that is a correct statement. So we have to pick the incorrect statement. So I'm eliminating that option. Anticoagulant should be started. What do you think? Should an anticoagulant be started? Yes, it has to be started. Why it has to be started? Because the patient is at risk for developing an embolic stroke. So I am eliminating this. Okay. Now you can see the ECG. By the way, what is the ECG showing you? It is definitely showing you a irregular narrow complex tachyarrhythmia with absent P waves, and you can see some fibrillary P waves. Definitely it is atrial fibrillation. Okay, atrial fibrillation. Now you can see cardioversion should be performed in hemodynamically unstable patients. Yes, a patient with atrial fibrillation, you will have to perform cardioversion. That is correct. So that is also not an incorrect statement. But what about the last option? Beta blockers are given in decompensated heart failure patients intolerant to calcium channel blockers. Look, in this particular patient presenting with an acute heart failure, in a patient, you will be cautious on giving beta blockers if there is an acute cardiogenic pulmonary edema. Remember, beta blockers can be used for heart failure, no doubt about it. It's very useful. But in the setting of an acute cardiogenic pulmonary edema, if you give a drug like a beta blocker, which has got a negative inotropic action, that may worsen the heart failure. So that is the only scenario where you will avoid beta blockers in a heart failure, when the patient is having a acute decompensated heart failure with a pulmonary edema. So you can just start the patient on beta blockers maybe later after the pulmonary edema subsides. So, that would be the incorrect statement. Answer would be option D, right? Right. Let's go to the next question. A 65-year-old male collapses at home and is brought to the emergency department. On examination, he is found to be pulseless. And the ECG shows the rhythm that is shown below. What do you think is the rhythm here? You can see a regular wide complex tachycardia, which is a monomorphic VT. So the patient is having a BT. So basically, this is a scenario of a patient with a pulseless VT. Correct or not? The patient is having a pulseless ventricular tachycardia. And what is the question? What is the most appropriate next step in the management of this patient? So in a patient with pulseless VT, ventricular fibrillation, what do you do? Do you go for cardioversion or defibrillation? You go for defibrillation. So can I already eliminate option C and option D? Yes, which say about the synchronized cardioversion, which is not given here. I've already eliminated, right? Now, could it be administration of defibrillation and then continue chest compression, or should you shock the patient and then look for the pulse? This is the algorithm, adult cardiac arrest algorithm. You can see that, you first do the CPR, and once you connect the leads and you identify the rhythm is shockable, for example, in this condition, which is a pulseless VT. So you've given the shock. Now, once you have given the shock, what should you do? Should you reflexly look for the, should you look for the pulse, or you continue with the CPR? What should you do? Should you, after giving the shock, should you check the pulse, or should you continue giving the CPR? It's again CPR. You give CPR for 2 minutes and then again look whether the rhythm is shockable, and then you go for the further management, the algorithm. Okay. So this is one common mistake that happens in emergencies as well. Many people, after giving the shock, they again look for the pulse. That's not the time. You have to continue chest compressions. Okay. So the answer for this question is going to be option A, right? Yeah. And you have to be very thorough with this algorithm as well, right? Okay. Now, next question. A patient died from myocardial infarction. Autopsy histopathology is shown. Estimate the time since injury. This is mostly a pathology question. So basically, when you have got such sort of studded polymorphonuclear cells, so much of neutrophilic infiltration is a striking finding. And I'm sure that you would know this particular table from Robin's textbook of pathology on the time since injury and the corresponding gross and light microscopic findings. And yes, you can have the appearance of neutrophilic infiltrate in the initial 24 hour itself. Yes, but I'm not going to select 1 day as the answer. Why? Because it is you can see studded neutrophils are there. So, you can see that it is slightly later that you get more prominent neutrophils, especially in the 3 to 4 day period will be the phase when you get the myocytes being studded with neutrophils. So the answer for this question is going to be option B, 3 to 4 days. Now, we are done with the cardiology questions. Let's now move on to the neurology questions. So basically, I am doing these as system-wise recalls. Now, after this, in the next session, which already has been informed to you, I'll be doing the next, the recall. And in that video, we'll be discussing the other systems. So we'll be doing it in 3 sessions. This is the session 1. We'll have session 2 and session 3 as well. Okay. Let's now go to the neurology questions. 40-year-old female presented with thunderclap headache. Very important. Thunderclap headache followed by loss of consciousness. The non-contrast CT of the brain and CT angiogram is shown. The moment you hear thunderclap headache, at an MBBS level, you are thinking about subarachnoid hemorrhage. Why did I say that? Because there are many possible differentials for thunderclap headache, and don't think that the only DD is subarachnoid hemorrhage. But still, for an MBBS level, thunderclap headache is usually in subarachnoid hemorrhage. Now, followed by loss of consciousness. Can there be a loss of consciousness in subarachnoid hemorrhage? Possible. Especially the catastrophic presentation of SAH can be with a loss of consciousness along with the headache, right? Okay. Now, NCCT of the brain and CT angiogram is shown. What is the diagnosis? Now, you can see options like meningitis. But again, see, meningitis can have headache, but it's not a classical thunderclap headache description. And also, patient is not having any fever. And also, it is said in the question that the non-contrast CT was taken. If it was a meningitis, what sort of CT would you have taken? A non-contrast CT or a contrast CT? Because you want to see meningeal enhancement, right? So if at all it was a meningitis, I would have gone for a contrast enhanced CT. So I'm eliminating that. So you can see that the non-contrast CT is very well showing you sulcal hyperdensities in the region of sylvian fissure, anterior interhemispheric fissure, the perimesencephalic cisterns. So you can see blood everywhere in the sulci, sulcal hyperdensity. This is often described, in such a diffuse pattern. This is often described as the star sign or the star of death. Okay, star of death sign. Okay, because it's such a catastrophic sign that you will see on the imaging. Now, what could this be? You're looking the CT on the other side as well, the CT angio on the other side. Can you guys spot an aneurysm here? Yes, this could very well be a berry aneurysm, especially involving the middle cerebral artery. You can see there is an aneurysm, and probably there has been an aneurysmal rupture that has resulted in a diffuse subarachnoid hemorrhage, right? Could this be a case of AV malformations? Well, in AV malformation, you will have, the artery, the nidus. You will have a definite nidus. I'm not seeing a nidus anywhere. So AV malformations also mostly would produce a lobar type of cortical bleed more commonly. Okay, more commonly. It can even produce, SH also, but more commonly a lobar cortical type of bleed I'm excluding. So extradural hemorrhage is usually the biconvex hyperdensity. So that is also not seen. So here my answer is going to be a subarachnoid hemorrhage. Option D is going to be my answer. Okay, right. Let's go to the next question. 58-year-old man presents with a right-sided weakness of the arm and leg accompanied by left-sided complete facial paralysis. Now, halt. If I look at this, right-sided weakness. So there is a right hemiplegia and left-sided complete facial paralysis. So is it LMN or UMN? Complete facial paralysis means it is LMN facial palsy. So when you get an ipsilateral facial palsy, which is LMN type, not UMN, LMN type, and a contralateral hemiplegia, we are considering a crossed hemiplegia. And how do you localize the site of a crossed hemiplegia? Based on the cranial nerve nuclei that has been involved. So here, what is the cranial nerve nuclei that has been involved? The facial nerve. And where is the facial nerve? Is it in the midbrain, pons or medulla? It is in the pons. So I'm very confident that the lesion is in the pons. Okay, it's a crossed hemiplegia. And since it is a left-sided LMN facial palsy, there is a problem in the left side of the pons, right? And you can see associated with that, there is some sort of inability in moving the eyes horizontally to the left. So I know that there is abducen nerve there, but is it just, about the left eye abduction? They've said both his eyes horizontally to the left. What does this mean? Can anybody tell me what does this mean? Anybody in the comment section? Let me see. Deepanshu, Nafrin, Sharon, Fatima. Can you say, Ananya, can you tell me what is this? This is nothing but a abducen nucleus palsy or a gaze palsy. I call this a gaze palsy. So it is not the abducen nerve that is involved. It is the abducen nucleus that is involved. Yes or no? So based on this presentation, what syndrome is most likely? I'm already confident that this is some sort of a pontine stroke. Yes. And since it is involving the left half of pons, let me just come to this. Look at this diagram, which I've shown you in my lectures also. So there is some sort of a damage. So you can see this is the abducen nucleus. So I told you there is a gaze palsy. Gaze palsy means what is involved? Is it the nucleus? Let me just show the nucleus in red, and maybe the green is the abducen nerve. What do you think has been involved predominantly? Yes, both can be involved, but is the nucleus involved or not? If the nucleus is involved, you will get gaze palsy. If the nerve is involved, only ipsilateral abduction palsy. What do you think? Now it is, even if the nucleus plus nerve is involved as well, you will have the predominant gaze palsy here. Okay, so there is definitely involvement of abducen nucleus. And since the patient is having hemiplegia, I've told you in a brainstem stroke, if there has to be a weakness of one side, the ventral part has to be involved because the motor pathway go to the ventral side. So the problem is there is a stroke that is involving the medial part of pons both ventrally and dorsally. How did I understand that the dorsal part of pons is involved? Because the abducens nucleus is located in the dorsal part of pons. How did I understand the ventral part of the pons is also involved? Because the corticospinal tract goes through the ventral part of the pons. How did I understand the medial part of the pons is predominantly involved and not the lateral part? Because you can see the location of the abducens nucleus is in line with the medial part of the pons and not the lateral part of the pons, right? Okay, so that is clear. And you can very well see the facial colliculus as well, the facial nerve that is winding around the abducens nucleus. So very well you can have facial palsy as well. So these are the pontine syndromes that are involving the sixth nerve and nucleus. And you can see out of this the Foville syndrome and the dorsal medial pontine stroke syndrome involving the sixth nerve nucleus. And you can see Foville syndrome, the sixth nerve nucleus causing ipsilateral gaze palsy. If the left sixth nucleus is involved, you'll not be able to look to the left side. You'll have contralateral hemiparesis and ipsilateral seventh nerve palsy. Correct or not? This is a crossed hemiplegia. Whereas next time they might ask you about another syndrome like Raymond syndrome and Millard-Gubler syndrome, which involve the sixth nerve. Raymond is ventral medial pons and Millard-Gubler is ventral medial and lateral pons being involved. Okay, right. So that is quite clear, and you must know about the manifestations as well. So for this question, my answer is going to be Foville syndrome. Why not locked-in syndrome? Locked-in syndrome means you will have bilateral signs, correct or not? Bilateral corticospinal tract being involved, bilateral facial palsy will be there. There will be horizontal gaze to either side will be affected. Okay, and the only movement that the patient can do is the upward and downward movement of the eyeballs, which is a vertical gaze, and that is because the vertical gaze is controlled in the midbrain. So when you get a locked-in syndrome, the midbrain, which controls the vertical gaze, is normal, but you will have all sorts of manifestations, and that is not what you're seeing here. Millard-Gubler, again, I just told you what Millard-Gubler is. Benedict syndrome, is it a pontine stroke or midbrain stroke? You guys tell me. It is basically a midbrain stroke. So in case of Benedict syndrome, you're going to get the involvement of the ipsilateral third nerve will be there. The corticospinal tract will be involved, resulting in a contralateral hemiplegia. And you will have the involvement of red nucleus, which can result in contralateral tremors, and in some rare circumstances, some ataxia as well. But these are the predominant structures that are involved in case of Benedict. But again, I told you I'm thinking of pons only here because it's seventh element. So Benedict is out of question. Okay, right. So coming to the next question. A patient presents with classical signs of Horner syndrome, including slight ptosis, meiosis, facial anhidrosis. So basically, it's Horner syndrome. Which of the following structures is affected by loss of sympathetic innervation in this condition? What do you think? So in Horner syndrome, what is responsible for this partial ptosis? It is the involvement of the superior tarsal muscle, which is the Muller's muscle that is innervated by the sympathetics. What about levator palpebrae superioris? LPS lesion can also result in ptosis, more of a complete ptosis, but that is innervated by the third nerve only. Sympathetic innervation is for the superior tarsal muscle, also known as the Muller's muscle. And this is a diagrammatic representation of the sympathetic innervation. And you can see the first order neurons for the sympathetic innervation is in the hypothalamus. Second order neurons for the pupil in the ciliospinal center of buds, and the third order neurons in the superior cervical ganglion. I want you to know this as well, because this is also a potential question on the sympathetic innervation of the pupil. Okay, and the postganglionic fibers of the third order neuron lie in the pericarotid plexus on the wall of the common carotid artery. So basically, this involvement can result in a meiosis. So this is again basically because of the the third order neurons that originate from the superior cervical ganglion being involved in Horner's and resulting in some sort of a meiosis. Okay, right. Let's go to the next question. Stroke in the Brodmann area 22 affects what domain? Does it affect expressive speech, receptive speech, visual, or auditory? What domain is being involved? Well, in the module on the aphasias, I have shown you this particular image. And you can see this is the Broca's area, this is the Wernicke's area. Wernicke's area is Brodmann area 22. Broca's area is Brodmann area 44. when there is a stroke involving the vernix area, probably because of the stroke of the inferior division of MCA that is supplying the vernix area, what is going to happen? There is going to be a problem in the receptive speech. Receptive speech. Okay, because you'll not be able to comprehend properly. Vernix area is very important for comprehension, and for expression the Brodmann area is very important. Brodmann area 44 is very important, which is the Broca's. So next time if they say about the expressive part of speech, it is Brodmann area 44. Receptive part, it is Brodmann area 22. So when there is a stroke involving Brodmann area 22, it can result in a receptive speech dysfunction resulting in a vernix aphasia. Resulting in a vernix aphasia. Okay, that's it. Now coming to the next question. What is preferred in the evaluation of syndromic meningitis? What do you think? Single pathogen PCR, RT-PCR, nested RT-PCR, arbitrarily primed PCR, and multiplex PCR. This again is a new question that came in the last, NEET PG, which is not a repeat question. That's why you will have new questions as well. So what do you think? What is the preferred evaluation? Now, my children, you should know what is a syndromic meningitis. Syndromic meningitis means a patient presents to you with features suggestive of meningitis, like fever, headache, neck stiffness, but you are not able to come to an exact conclusion. Is it bacterial, viral? So the etiological agent, you are in doubt. So in that case, you will have to evaluate for multiple pathogens. Okay. So it's like, the syndrome of the patient is meningitis, but again, you're not exactly sure on the etiological agent. Now, when you send the CSF sample for evaluation, here you have multiple pathogens in mind, like bacteria, viruses. So rather than testing for each of them, if you can test for all these together, that is called a multiplex PCR. You can almost test for 14 pathogens, including bacteria, viruses, and you can get the result in almost 1 hour. Okay, so you've got various panels for that. That is called a multiplex PCR, right? Okay. Next question, a patient underwent a brainstem tumor excision and subsequently developed loss of gag reflex and dysphagia. Which of the following cranial nerves are most likely involved? Okay, so there is some sort of a brain tumor in this patient and he has undergone excision. So post that excision, he has developed loss of gag reflex and dysphagia. So something has happened, during the tumor excision that has resulted in this. Now for gag reflex, which is also known as the pharyngeal reflex, you should know what is the common stimulus that is applied. The stimulus is a touch involving the posterior pharyngeal wall with a cotton swab. And what is the afferent for that reflex? It is the ninth nerve. Where is the reflex center? Very important. Which part of the brainstem? Medulla. And where is the efferent? It is the 10th nerve. And the response is a constriction and elevation of the oropharynx. So there is a pharyngeal muscle constriction and also the elevation of the palate as well. That is the response. Basically, this gag reflex is a protective response so that nothing actually goes inside your windpipe. So that is a protective reflex, gag reflex. So what do you think? Loss of gag, it's basically the 9th nerve and the 10th nerve. Okay, so the glossopharyngeal and the 9th nerve and the 10th nerve is getting involved. So the glossopharyngeal as okay, right. So you trigeminal and facial, hypoglossal and accessory, vagus and hypoglossal, no. So it's basically the 9th and the 9th, that is the glossopharyngeal, and 10th, that is the vagus that is actually getting involved. So maybe the tumor was there in the medulla and while they removed it, there must have been some sort of a damage. Okay. So when there is some sort of a damage involving the efferent or the center, in this case, the damage would have been to the reflex center that would have resulted in this sort of absence of gag reflex and subsequently dysphagia as well. Okay, answer is option A. Coming to the next question. A patient suffered spinal cord trauma in a recent road traffic accident. The neurological examination reveals a right-sided plantar extensor response. Which of the following is the most likely associated finding? Now look at this. A patient has got a road traffic accident recently. Okay. And there is a spinal cord trauma that is also mentioned. And when you look at the neurological examination, what are you seeing? Are you seeing a unilateral finding or a bilateral finding? You are seeing a unilateral finding. So they've already mentioned cord trauma after road traffic accident with unilateral finding, in terms of motor response. So what do you think? Is it going to be a pan-cord syndrome, hemicord syndrome? What is likely to happen? It is likely to be a hemicord syndrome, which is also known as Brown-Sequard syndrome. Hemicord syndrome, which is also referred to as the Brown-Sequard syndrome. Brown-Sequard syndrome. Correct or not? And they're asking what is the most likely associated finding. Now, in Brown-Sequard syndrome, again, coming to a diagram that I've taught you in the class. So certain tracts you have to be aware about: the dorsal column, the lateral corticospinal tract, the spinothalamic tract. So here there is a damage involving one half of the cord, hemicord. So when there is a damage involving the corticospinal tract, you can have a right-sided extensor plantar, which means probably the patient has got a trauma to the right half of the cord, and that is why he is having a ipsilateral motor finding. Well, what about any sort of weakness? Well, according to the recall that I got from the students, nothing was mentioned like that. But again, I'm expecting weakness in this patient. Okay, but based on the recall that I got, the patient is having a unilateral motor finding, which is again a right-sided cord. How did I understand it is the right side of the cord? Because the patient is having a right-sided extensor plantar. Because when there is a cord damage, which is, remember, the corticospinal tract is already crossed in the lower part of medulla. It does not cross any further. So you'll have an ipsilateral finding, right-sided extensor plantar. So they're asking what is the associated finding. Now, can this be a loss of proprioception on the left side? See, when there is a dorsal column also getting involved, the loss of proprioception will be on the ipsilateral or contralateral side. Ipsilateral side. So it has to be on the right side itself, but it is given here left side, eliminating the option. Okay, next, loss of pain sensation, spinothalamic involvement. Now, spinothalamic involvement, again, it's a crossing tract in the cord itself, right? So when there is a right-sided spinothalamic tract being involved, it is the left side of the leg, or the left leg that is actually getting involved. So this is wrong. It should have been loss of pain sensation in the left side. Now, what about the last option, fasciculations and muscle atrophy? So it is a recent road traffic accident. We know that, first of all, UMN lesions typically do not produce fasciculation and wasting, correct or not? And even if at all, there has to be some sort of muscle wasting, it has to be in a long-standing disuse atrophy. So that is not what I'm actually seeing here. It is a recent road traffic accident. So here I'm expecting an ankle clonus. When do you see an ankle clonus? When there is extensive corticospinal tract damage. So in this case, when there is an extensive corticospinal tract damage, I may get an ankle clonus. So my answer for this question is going to be option A, right? Okay. Now, which of the following proteins is characteristically accumulated in the brain of a patient with Alzheimer's disease? So all of you know that Alzheimer's disease is a neurodegenerative disease. And in neurodegenerative diseases, you can have abnormal accumulation of proteins. And always remember, in such neurodegenerative diseases, what are the common proteins that may be accumulating? One is amyloid. Then you can have tau protein. Then you can have synuclein, alpha synuclein. So these are the proteins that commonly accumulate in neurodegenerative conditions. Now, what about Alzheimer's disease? Can you tell me what are the proteins that may be deposited? Is it just amyloid? Not just amyloid, even tau as well. But the option does not say tau. Only beta amyloid was mentioned in the options. That is my right answer. So always remember, in Alzheimer's disease, you can have deposition of beta amyloid as well as tau. Suppose if this was not there in the option, beta amyloid, and tau was there, yes, then I would have gone for tau as the answer. Whereas other neurodegenerative diseases like Parkinson's disease, dementia with Lewy bodies, multiple system atrophy can have which other protein? Alpha synuclein, which is why these are known as synucleinopathies. These are known as synucleinopathies, right? And what about the next option? Frontotemporal dementia, progressive supranuclear palsy, corticobasal degeneration. These are tauopathies, wherein you will have deposition of tau protein. Okay, tauopathies. So in these, amyloid will not be there, only tau. Alzheimer's, both tau and beta amyloid. And look at this diagram as well, just to teach you how amyloid protein is getting deposited in patients with Alzheimer's disease. You will have a long peptide protein, which is the APP, amyloid precursor protein, which is acted upon by the beta secretase and alpha secretase. And this beta secretase product is then again acted upon by the gamma secretase, and a subsequent cleavage by the gamma secretase will result in A beta 42, which is a toxic amyloid, then a non-toxic amyloid, which is A beta 40, and then another byproduct, which is pre3. But the problem maker is this one, the A beta 42 amyloid, which is a toxic amyloidogenic particle which can cause neurodegeneration. Okay, so the answer for this question is option A, right? Okay. Coming to the next question, a patient underwent right upper limb amputation 2 years back. Now the patient experiences severe pain in the region of amputated limb. What is the finding that will be seen in the PET scan? So he has undergone a right upper limb amputation. See, you see lot of these questions. I'm discussing this under neurology. This is integrated with physiology. So basically what I am meaning by these system recalls is to bring in the core medicine questions as well as the integrated questions, so that in one roof you'll get, okay, what are the questions asked from cardio, what are the questions asked from neuro, and it's easy for you to revise as well, right? And I've shared the PDF also with you for your ready reference as well. Okay, so stay tuned for the next session also, right? So patient underwent right upper limb amputation and severe pain in the region of amputated limb. So what is this? This is nothing but a phantom limb pain. This is nothing but a phantom limb pain. Okay, phantom limb pain. Thank you so much, Dhawan sir. I can see Dhawan sir in the comment section. Thank you so much, sir. Thank you so much. Wonderful to have you, sir. Thank you, sir. So phantom limb pain. Right. 1 second. Yeah. I hope. Yeah. So I'm sure that all of you have heard about this cortical plasticity. So following this amputation, there is some sort of a cortical rearrangement that actually happens in the homunculus. Now, suppose if there is actually, suppose, your right upper limb is being amputated. Still, there is a region of your brain that is actually, associated with the control of this area. Now, if this is amputated, though that area is of not of much use now, as time goes by, it's a vacant area, no function, what will happen? You will definitely have some sort of a projection from the adjacent fibers to overlap the somatosensory cortex, because something that is left vacant is always open for intruders, right? So right upper limb amputation means it is related to left somatosensory cortex. So the adjacent fibers will actually project into the left somatosensory cortex, and that is the finding that you're going to see in the imaging. Okay, right. So that's it. It's option B, right? Coming to the next question, a 32-year-old pregnant woman in her third trimester presents with seizures and elevated blood pressure. So my dear students, there were two questions that are related to the same. One came on each session, again stressing the importance of previous year topics. Okay, right. So 32-year-old pregnant woman, third trimester, seizures and elevated blood pressure. She's diagnosed with eclampsia and started on IV magnesium sulfate therapy. Which of the following is not routinely monitored during magnesium sulfate administration in this patient? Now, what do you think? I'm sure all of you know urine output is definitely monitored. That is not the answer. Deep tendon reflexes like knee jerk, definitely monitored, not the answer. Respiratory rate, definitely monitored, that is not the answer. So what is not routinely monitored during magnesium sulfate administration? It is the serum magnesium levels. Only in certain rare circumstances will you go for checking the serum magnesium levels, not routinely monitored, right? Okay. Coming to the next question, again, came in the next shift. 28-year-old female is being treated for eclamptic seizures, which is an indication to stop magnesium sulfate. That was asked. Again, look, the topic is important. Knee jerk is present. That's not an indication to stop. It should have been knee jerk is absent. So I'm eliminating this option. Respiratory rate less than 18. Well, if it should be more than 12. So even if it is less than 80, I am comfortable, there is no way that is going to be an indication. If it is 16, 14, I'm comfortable, no problem. Okay. Next is visual disturbance. That is also not an indication. In fact, not an indication to stop. In fact, that is one of the manifestations that can occur in an eclampsia, and that itself is an indication that you should be giving this medication. So that is not an indication to stop. But the last one, urine output 60 ml 4 hours. It should at least be 100 ml, right or wrong? So 60 ml in 4 hours, which means per hour it's only 15 ml. So that is significantly low. And what is the importance of that? Because magnesium sulfate is excreted via the kidney. And if you are having this sort of a renal dysfunction, there is always a chance for magnesium toxicity. It's not that magnesium toxicity manifests as a oliguria, but a patient having a decrease in urine output, there is a high chance of magnesium toxicity, and hence this is an indication to stop. The answer is going to be option D, right? Next question. 45-year-old man with a history of depression was initially managed with amitriptyline, but his symptoms remain uncontrolled. His treatment was modified to include MAO inhibitor and sertraline. What do you think? An SSRI MAO combination, always at risk of serotonin syndrome. Very important. At risk of serotonin syndrome. At risk of serotonin syndrome. Right? So soon after, he developed agitation and seizures. On examination, he exhibited marked hyperreflexia and tremors. Do you think the manifestations support serotonin syndrome? Agitation, seizures, hyperreflexia, tremors? Yes, very well can be explained by serotonin syndrome. And which of the following is the most appropriate treatment for this condition? What do you think? In a serotonin syndrome, you have to give serotonin antagonist. And what is it? You can give the patient cyproheptadine. That is going to be the answer. And I want all my children to be very, very, very familiar with this table. And what is this? Showing a comparison between serotonin syndrome and neuroleptic malignant syndrome. Both of them are previous year topics. Both of them. Both are PYTs. And you must be able to differentiate between them. Remember, for a serotonin syndrome, the triggering factor will be a serotonergic agent, as in this case. In a neuroleptic malignant syndrome, it is triggered by dopamine antagonist. Serotonin syndrome will have acute onset, whereas neuroleptic malignant syndrome, it is acute to subacute. There can be 3 to 9 days gap between the use of antagonist and the development of symptoms. But remember, both these syndromes can have certain overlapping features. And I want all my children to know what are the overlapping features. Hypertension, tachycardia, tachypnea, hypothermia, diaphoresis, altered mental status, rigidity. These are the overlapping features which may be seen in both serotonin syndrome and neuroleptic malignant syndrome. But myoclonus and tremor, remember in this patient we had tremor. So myoclonus and tremor features is more suggestive of serotonin syndrome. Okay. And hyperreflexia again was there in this patient. That is suggestive of serotonin syndrome. Whereas neuroleptic malignant, it is hyporeflexia. Dilated pupils, again, not mentioned in the question, but again, you should know that is a feature. It's a previous year topic. Whereas neuroleptic malignant syndrome will have normal pupil. Hyperactive bubble sounds in serotonin, nothing like that in neuroleptic malignant syndrome. So trigger has to be eliminated and you have to give serotonin antagonist like cyproheptadine. And in neuroleptic malignant syndrome, you eliminate the trigger, give dopaminergic agents like, bromocriptine can be given, and other agents which I've already taught you in my lectures. Okay. So the answer is option A, right? Okay. Coming to the next question, 45-year-old man with a long-standing history of alcohol use disorder is admitted to the hospital. He reports experiencing anxiety, tremors, and agitation. So what is it? Alcohol withdrawal that starts 24 hours after his last alcoholic drink. It's alcohol withdrawal state. And which of the following medications is most appropriate for managing the alcohol withdrawal? You will be giving the benzodiazepine, that is lorazepam. Okay, so disulfiram, that is actually used for alcohol dependent states, but not in case of an acute alcohol withdrawal. Formipazole in case of the ethylene glycol poisoning or methanol poisoning. Buspirone is an anxiolytic, so that's not going to be the answer. It is option A. Coming to the next question, 70-year-old man with a known history of frequent falls presents with complaints of headache and confusion. CT brain provided what is the most accurate diagnosis based on the clinical presentation and imaging. So history of frequent falls, headache and confusion. Okay, they have not mentioned that he had a recent fall or something like that. So you can see it is not a hyperdensity that you are seeing, it's more of a hypodensity. So if it was an intraparenchymal hemorrhage, subarachnoid hemorrhage, epidural hematoma, you would actually see the hyperdensity. But since it is mostly hypodense, this could be a chronic subdural hematoma. Answer is option A, right? Okay. Next, a patient presented with symptoms of headache and confusion and is recently diagnosed with a cerebellar mass on imaging. So probably related to the cerebellar mass, he's having some sort of headache and confusion. The patient's family history is notable for both brain and kidney tumors. Which of the following genetic syndromes is most likely responsible for this clinical picture? So brain, cerebellar involvement, kidney involvement, I'm sure, by this time you would have guessed it is von Hippel-Lindau, because in von Hippel-Lindau you can have cerebellar hemangioblastomas, cerebellar as well as retinal hemangioblastomas, and also renal cell carcinomas. And this is due to the mutation of the VHL gene that is located on chromosome 3p, right? Okay. So this table from Harrison apparently looks very much exophthalmogenic, a big one. Okay, but again, it's very, very important. You can see even the options, von Hippel-Lindau, tuberous sclerosis, neurofibromatosis, Lee-Fraumeni syndrome. So you can very well see that in von Hippel-Lindau, kidney, cerebellum, pheochromocytoma, these are manifestations. Answer is option C. Okay. Coming to the next question, 30-year-old patient presents with generalized tonic-clonic seizures and is admitted for evaluation. The contrast-enhanced CT of the brain reveals a ring-enhancing lesion. So which of the following investigations would be most appropriate to confirm the diagnosis? You know that there are many differential diagnoses for a ring-enhancing lesion. It could be conditions like, say, a tuberculoma, neurocysticercosis. But once you get a ring-enhancing lesion, the next step is usually an MR spectroscopy. Why? Because, see, for a common condition like tuberculosis, it could be a tuberculoma. And this tuberculoma will show a lipid lactate peak. Lipid lactate peak, I'm sure this might have been taught you in radiology as well. Lipid lactate peak. So you'll have to go for NMR, that is magnetic resonance spectroscopy, because that will actually help you. If you find lipid lactate peak, yes, it is tuberculoma. Else you can consider other differentials like neurocysticercosis. Okay, right. CB-NAT of CSF, that is not very sensitive. So don't think that that is 100% sensitive for any sort of condition. No, because this is a parenchymal involvement. And this is actually when there is a meningeal involvement is where you will look for the CSF. But here it's a parenchymal, because the parenchyma is showing a ring enhancing lesion. B scan of the ultrasound, in ocular neurocysticercosis, you can go for that. But again, for the next appropriate step would be again MR spectroscopy, because don't think that all cases of neurocysticercosis will have ocular involvement. Only if there is a specific ocular finding will a B scan ultrasound be of use in case of a neurocysticercosis. Next question, given below are the contrast enhanced MRI brain sequence and diffusion weighted MRI sequence of a patient with intracranial space occupying lesion. What is the likely diagnosis? So you can see the first image is the contrast enhanced MRI. You can very well see that there is a ring enhancing lesion. You can see that there is a ring enhancing lesion. And ring enhancing lesion has several differential diagnoses, right? And you can see the differential diagnosis of ring enhancing. I want all my children to be very thorough with this list. Metastasis, cerebral abscess, tuberculoma, lymphoma, subacute infarct, toxoplasmosis, neurocysticercosis, radiation necrosis, demyelination, resolving hematoma. All of them are differential diagnosis for ring enhancing lesion. So when I look at the first one, I'm not able to exactly say what is a likely diagnosis. If there was some sort of a conglomerate ring enhancing lesions, I would have gone for maybe tuberculoma, but I'm not seeing any sort of a conglomeration. What I'm seeing is there is a hyperintensity in the DWI. So the first one was the T1 post contrast. That is a contrast T1 post contrast sequence. That is the first one. And the next one is diffusion weighted. Now remember, mark my words, when you have got a ring enhancing lesion which shows diffusion restriction, that means there is pus in the lesion. There is diffusion restriction. There is difficult for the protons to diffuse across. That means there is pus, and that means there is abscess. Okay, none of the other options, okay, will show, because see, even if it is an infarct, okay, it has to be in the acute stage. There can be a diffusion restriction possible. You might ask me, so don't you think that diffusion restriction is seen in infarct? But let me ask you something. Do you think an acute infarct will show a ring enhancing lesion? An infarct can show some sort of ring enhancement, but that is only in case of a subacute stage, not in the acute stage. Never going to have that. Okay, right. So the answer is going to be option A, that is abscess. Okay, right. And you can see here, subacute infarct can have a ring enhancing lesion, right? Okay. Next is what is the likely diagnosis? Okay. Dandy-Walker malformation, Arnold-Chiari malformation type 1, vein of Galen malformation, corpus callosal agenesis. So what are you seeing here? Are you seeing the tonsil, cerebellar tonsil descending? I've just marked T. If you are comfortable, I'll just highlight this is a cerebellar tonsil. Can you see the tonsillar herniation has been there? And that is actually pressing on the lower brainstem and the upper cord, yes or no? So what is this? You're thinking about an Arnold-Chiari malformation type 1. So Arnold-Chiari malformation type 1 is associated with the descent of the cerebellar tonsil. This patient can have, some sort of ataxia. The patient can have nystagmus. Findings can be there. And that's going to be my answer. In case of Arnold-Chiari malformation type 2 also, you can have a tonsillar descent, but again, you will have associated myelomeningocele as well in Arnold-Chiari malformation type 2. And what is the other finding that may be seen in this patient? Although it is not there in this patient, I'm just waiting for the comment section. Dr. Sangeeta Pandey, Dr. Nafreen, Dr. Amit Pathare, can you just comment? What is the other finding that may have been there, but it's not there here, but something else, you would anticipate? Can you answer in the comment section? Yes, Fatima Rasha, you have answered it correctly. Syringomyelia. Though there is no syrinx, I cannot spot any syrinx here. But again, in any patient with a Arnold-Chiari malformation type 1, you have to look out for a syrinx. Now, just to show you the other images, when you have got such sort of a large posterior fossa, a posterior fossa cyst, where the cerebellar vermis is absent, the posterior fossa is very large, posterior fossa cyst, that is when you are going to think about a Dandy-Walker malformation. Dandy-Walker malformation. Okay. And what about this one? You can see this is the vein of Galen malformation. Vein of Galen malformation. Mostly in your scenario, a child with a heart failure might be the presentation. Okay. So vein of Galen malformation. Okay. And this one is corpus callosal agenesis. And mind you, another possible radiology MCQ is this racing car sign that may be seen in corpus callosal agenesis. Okay, right. So just wanted to take you through the other options as well. Coming to the next question, 45-year-old patient with a known history of Wilson's disease presents with neurological symptoms. Most accurate test, again we have discussed this, Wilson's disease, whether it be neurological symptoms or hepatic symptoms, the most specific test will be a liver biopsy and an assessment of the hepatic dry weight of copper. If the hepatic dry weight of copper is more than 200 microgram per gram dry weight, that is when you can diagnose Wilson's. For the screening purposes, the sensitive tests are the 24-hour urinary copper excretion and the serum ceruloplasmin. The more preferred one as a sensitive screening test is the urinary copper excretion. For this particular question, it is the hepatic copper content by liver biopsy that will help you in confirming the diagnosis, right? Okay. Coming to the next question, a 45-year-old woman presents with ptosis and generalized muscle weakness that improves with rest. She also reports difficulty in swallowing and has visible jugular venous distension on her thorax. Okay, on her neck is what is meant. Okay, in the neck, JVP is distended. CT scan is provided below. What is the diagnosis based on the clinical features and imaging? Now, whenever you hear about ptosis and generalized muscle weakness, even if you don't know anything about CT scan, you know that there is myasthenia gravis, okay, that improves with rest and worsens with activity. Now, some sort of swallowing difficulty, JVP distension. So there is some sort of a mass that is compressing. And what is a mass that can occur in such a patient with, myasthenia gravis? It's usually a thymic pathology, which is usually a thymic hyperplasia or thymoma. Correct or not? Thymic hyperplasia / thymoma. Correct or not? Okay. Now the question is, what is the likely diagnosis? And if you look at the image as well, so this is the ascending aorta, this one. Okay, let me just mark once again. This is the ascending aorta. This is the main pulmonary artery. This is the descending aorta. And you can see this is an anterior mediastinal mass. Anterior mediastinal mass. And thymoma is an anterior mediastinal mass. Yes, and the answer for this question is thymoma. And we know that Pancoast tumor is not associated. Adenocarcinoma, small cell carcinoma, no. It's only thymoma, right? Okay. Coming to the next question, again, more of a physiology question. Which ion is responsible for the resting membrane potential of nerve? What is it? It is potassium. The efflux of potassium is responsible for maintaining the resting membrane potential of the nerve. Next question, patient presents with vertigo, vomiting, gait ataxia and nystagmus after road traffic accident. Which part of cerebellum is affected? Very good question. Now, see, let me tell you, gait ataxia. This can happen due to involvement of vermis. You can have involvement of flocculonodular lobe. So just because somebody has a gait ataxia, I cannot say it is vermis or flocculonodular lobe. I cannot say. But what helps me here is the other associated features like vertigo, vomiting, and nystagmus. Can anybody comment the answer here? See, in my lectures, I have told you this is the anterior lobe, posterior lobe, and flocculonodular lobe. And in the functional classification, I told you the flocculonodular lobe, which can be equated with the vestibulocerebellum, is having connections with the vestibular nuclei and is important for balance and eye movements. So, when you have got vertigo, so the vestibular disturbance is there, and nystagmus, all this together tells you the site that is involved is flocculonodular lobe, because you are not going to get these vestibular symptoms in a vermian lesion. You will get gait ataxia. So gait ataxia can happen in both vermis and flocculonodular lobe lesion. But when you get vestibular symptoms along with this, you have to think about flocculonodular lobe involvement, right? Okay. Next, identify the field defect. I think very simple one. It is basically a left homonymous seminopia, but again, the examiner did not even trouble you like that. It was just mentioned homonymous seminopia. That is the answer. Field defect is again, you can consider this to be an ophthalmology question, but for medicine, this comes under neuro-ophthalmology part as well. Okay, so we all believe that medicine it's like a big umbrella. Okay, big umbrella, and I think many of the other subjects that you study, it's basically a part of medicine, is what I believe. Okay, right. So that is it about the discussion. I think we have discussed around 41 questions, if I'm not mistaken, from neuro and cardio of the questions that were asked in the previous NEET PG. Remember, we had 2 sets of questions. That is why these many number of questions are there from the neuro and cardio part. So I hope this sort of a discussion, system-wise discussion, is useful for you, is what I understand. You can please let me know as well. So we have covered cardio and neuro system-wise MCQs, 41 questions of the previous session. and we'll be going for the remaining systems in the next 2 sessions that will be coming up. I hope you are already staying in touch with me in my academic WhatsApp groups as well. So I'll be letting you know about the next session in the group. I mean, I'm sure that you would have already noticed that the announcement is already there for the next session, and you can stay connected with my academic Instagram page as well. Yes, so thank you everyone. Sharon, Sharon, Abhay, Deepanshu, Gokul. Yeah, so I'm glad that you all found this session to be useful, and I kept it fast-paced session so that your time is also saved. And I've already shared the PDF with you for any sort of last-minute revision as well. Thank you so much, everyone. Yes, Indu, Apirami, Fatima, thank you so much, everyone, for joining. And good luck for the exams, and stay tuned for the remaining sessions as well. Thank you so much.